Alrighty, I see a few of you joining. We're going to get everyone just a couple of minutes before we begin the webinar. We are going to record this, and it looks like that number has kind of steadied out, so perhaps we'll go ahead and get started. Thank you, everyone, for your time, and welcome to our 2026 Emergency Medicine Reimbursement Update. Diana and I will be your hosts today, and our agenda today is really going to cover kind of a wide variety of topics. We're going to look briefly at the state of the industry, cover a little bit about what just happened in the final rule from CMS regarding Medicare reimbursements. We're going to look at our out-of-network industry trends. We're going to go through some documentation best practices, and then we'll have a Q&A session at the end. You should see a question box kind of at the top of your screen. We'll be taking your questions from there. Yeah, so let's go ahead and start with the state of the industry for emergency medicine. Hopefully you all had a chance to take a look at it. If not, I'm happy to send it to you. But a number of partners in the industry got together and pulled quite a significant amount of money together to have RAND take a deep dive into our industry, looking at 4 years of data, about 40 million plus claims worth of data. And what they found is what we all knew, what we've all been living, is that our reimbursement is going down. About 1 in 5 ED claims in general goes unpaid. That is a combination of your uninsured rates and then the patient cost share. So when a claim is adjudicated, but it goes against the entirety of the patient's cost share, and they don't have the ability to pay it, right? Even when you turn them to collections, it's just unpaid. Your commercial payments dropped during this time frame, and that is a function of the NSA, which we'll be talking about briefly today. And you ask, why would an in-network rate drop regarding, because of a law that had to do with out-of-network behavior? Well, the law basically allowed or allowed the insurance companies to pay less, and so they looked at their really well-paying contracts and sent cancellation letters and just brought the whole of the in-network rates down over this period. And then, of course, the out-of-network rates plummeted almost by half. So really significant hits to our industry. For this time period, Medicare payments went down, but that Medicare Part B payments, because there is no inflationary adjustment on the whole for the last couple of decades, are really down as adjusted for inflation by about 30+%. So really significant. And because Part A, which is where the facility gets paid, is adjusted for inflation, our hospital facilities, healthcare systems are enjoying a nice sort of bump up every year from Medicare. So kind of a bitter pill to swallow, but that's what the data shows us. Next slide. So also across the industry, you're well aware of the AI sort of boom. And so states now are looking at how is AI being used by the payers to adjust claims, adjudicate claims, downcode claims. And so, EDPMA is looking at this. We're tracking the states, really with an eye, though, a very careful eye, to be sure that it doesn't become a double-edged sword, and they don't turn and say, because certainly we have seen some proposals here and there to say AI cannot be used in any part of either the creation of a claim or the adjudication of a claim, right? Because AI is a very useful tool inside the RCM process to bring efficiency, accuracy, and speed. So just watching sort of state by state, EDPMA has been a big partner here for us, really watching state by state for downcoding laws, and again, laws that might impact how a claim is actually created. And so certainly if your state is considering laws, we'll be reaching out to you as well. Yeah, next slide, that's perfect. So let's touch on Medicare reimbursement. Okay, just high level conversion factor. We got a little bump up from CMS this year, and that's a factor of a couple of things, right? Congress kicked in 2.5%. And then Medicare was actually able, through budget neutrality, to put a little bit of more money on the table. Usually budget neutrality causes CMS to bring down the conversion factor, and then we have to go crying to Congress and ask for some more money. Congress, through H.R. 1, gave us a little bit more money, and CMS, through budget neutrality, was able to give us a little bit more money. And then in 2026, this is the first time we see the split for the advanced alternative payment models. You might know it as an ACO. If you're in an ACO and you qualify, you meet the minimum standard, minimum volumes. So there's two conversion factors, and your client manager can help you know which one you qualify for. So if you are in that advanced alternative payment model, your conversion factor is $33.57. So that's about a 3%, almost 4% bump from last year. If you are in a non-APM model, you're looking at $33.40, which is still 3.25% bump from last year. So that's the good news. And we're going to get to what that actually means, though, for emergency medicine here on the next slide. But it's worth noting that the continuing resolution, right? The budget, the government shut down, the big brouhaha, and we finally got through it. They passed a CR. The CRs are short-term fixes. And why we care about what happens in the CR is that we have relied on Congress to fix a few things that CMS, through their own budget power, cannot address. So a number of you practice in areas of the country where, theoretically at least, the cost of living is lower. So in your multiplier, when we figure out how you actually get paid by CMS, the multiplier, the geographic price cost index, the GPCI, is less than 1. And as a result, you're multiplying times something less than 1. So your reimbursement goes down as a result of that. Congress years ago said, we're not going to let the more rural and critical access parts of our country, because that's generally where the cost of living is less, go down. So they always have set a floor and said, any place where CMS has set a GPCI of less than 1, we're going to bring it up to 1. And so we rely on Congress to fix this every year. And lastly, for those of you that are providing the telehealth services, this CR did extend the waiver on the originating site, so that protection we got coming into the public health emergency has been extended at least through January 30th. Next slide. So let's get into kind of what did all that mean? Well, great, I got a little bit more on my conversion factor. Does that mean I'm going to make a lot more? Not yet, not really. So stepping back for a minute, right? The way you get paid is conversion factor times total RVU. What CMS did, which was not favorable to emergency medicine, critical care, hospitalists, and for reasons that aren't super clear to me, infectious disease, is they took away half of something called our practice expense. So when you look at total RVU, it's a factor or a function of 3 things: work RVU, practice RVU, and then it's called malpractice or practice liability. So there's 3 factors that make up the total RVU. You can see on your screen that each of those are multiplied by that GPCI that I just mentioned a year ago. So if you practice in a part of the country that has a lower cost of living, or is that more rural or critical access, you are the one with a GPCI less than 1, and you can see where that hurts you unless Congress steps in with protection. But looking at, again, the total RVU, what CMS did is take away half of the value of the practice expense for services rendered inside a hospital, inside of a facility. The logic being that you don't have as much practice expense as if that same service were rendered in an office that you were paying the rent on and paying for the lights and yada yada. Now, course, we have practice expense. Emergency physicians have practice expense. You pay a billing company, you pay accountants, you pay for payroll, schedulers, CMEs, recruiting costs, lots of practice expense. So this is a problem. If we go on to the next slide, we can see how this marches out. For your E&Ms, the change in your practice expense RVUs was very minimal, right? In 25 for 99284, 0.57 to 0.45, right? And then with your slightly higher conversion factor, you're actually going to get a little bit more for your 99284. Same with your 99285. So there you're going up. But if we get to the next slide, $99291, the practice expense, or practice expense, you lost 0.42. So now we're losing about $6 on our critical care, and we're losing almost $10 on our observation code. We're losing $3 on our central line and about $6 on our complex I&D. So, and remember, we're relying on the one-year bump from Congress, and when that goes away, we're going to be losing even more. Next slide. So let's look at out-of-network trends. Talking about the No Surprises Act. Right now, the independent dispute resolution is working, but the payers are not always paying what they owe. So we're winning, it says 80+%, more like 85% of the time. But they don't always pay, the payer doesn't pay when they should. Sometimes they pay the wrong amount. But still, it's important to participate because not participating is just lost dollars. We have gone to Congress and we have said it's a problem. And if we go on to the next slide, Congress has finally heard us. There's actually a bipartisan piece of legislation that's moving through the process. It was introduced by Congressman Greg Murphy, bipartisan, and it addresses this issue. It puts some teeth into the law that says, look, once the arbiter has issued their ruling, there is a 30-day time span in which the losing party, generally not us, the payer, must follow the law and pay the winning party. And if they don't, there are penalties and basically penalties if they don't. And so it gives us some teeth, right? A little bigger hammer to get the payers to comply with the law. So really excited. We've been kind of working on this for years. So really excited to see the payers, or at least this piece of legislation, moving along its pathway. Next slide. Next is the Anthem policy that some of you have written to me about. Anthem put out a policy that said for the health systems, if at any point along the way their patient encounters a provider who is not in network, they are going to penalize the facility payment by 10%. And the whole industry they're just going crazy. Like, what is this? Wow, it's hard to even just ingest. We took this to Congress when we walked the Hill about 2 weeks ago. There was a big industry professional letter from, I think, 30 different professional organizations that just went to Congress on this. I mean, this is like the dark old days of coercive contracting. Right now, emergency medicine is exempt. However, I think that's a short timeline. And will other payers follow suit? So know that we are actively working against this policy and more to come on this. All right, and I think it is Diana's turn.
Thank you, Dr. Brault. Some things that are happening in the industry, things that are happening to you where you have no control, but we're going to look at some things that you do have control over to try and help yourselves prevent denials and downcoding. As Dr. Brault mentioned, AI is a big player in claims review and adjudication of claims. The initial review of the claims that are submitted are done with an AI program. Not only are they looking at diagnoses, but they have a lot of things programmed into their review. For instance, if we bill a level 5 on a 32-year-old male for chest pain, their AI will automatically downcode a level 5 to a level 4 because the age of the patient doesn't fit the usual parameters of men with MIs. So a 32-year-old male couldn't possibly have a high-level cardiac workup according to their systems. So once the claim moves to a second-level review, then a human gets involved. But we have found out, we have an employee in our coding management that used to work for one of the main payers, and she's given us some insights into how things are actually done by the payers. And she said the payers intentionally hire non-clinical people to do the claims review, so they get a higher rate of denials and down codes, because those people cannot connect the clinical dots. They don't know what a troponin result should be or what it means if it's elevated, which means that you need to be really clear in your documentation to make your points about what you're doing. We don't have the history and physical to fall on anymore to help get those billing levels up. It's based solely on your MDM. And so you need to really convey your thought process in ink so you can get past those people who have no clinical expertise. If you're making a high-risk decision, say so. Yes, if you order a CT with contrast, it does meet high risk. But we have some payers saying they're not going to follow the ASAP FAQs. They of course can make up their own rules. So they say, no, we don't believe it. We don't agree with it. We're not going to follow it, which means that just by ordering a CT with contrast, you will get credit for high risk, but it won't be supported in the documentation should somebody come along, review that chart and say, no, this is only a 4, a moderate risk. So it's important that you take the extra time. Remember, you're protecting your revenue, your livelihood. So if you take the extra time to include some documentation that really makes it clear to anybody reading the chart that there was a high risk management decision involved. And you can use pretty much the same basic statement for a lot of things, for your medications that are potentially toxic, for your procedures in the ED, for your CTs with contrast medium. So while you're making the statement that you made a high risk decision, you're also coming back and kind of counterbalancing that med-mal-wise by saying that you discussed the risks and benefits with the patient and a shared decision was made to proceed with the study. One thing you want to remember, don't practice macro medicine. If you have a chart that's made up of a ton of canned documentation and dot phrases, that will be really closely scrutinized by the payers. One of the other things we found out is when a claims reviewer is looking at your particular claims individually, they will pull up 4 of your claims and put them on 4 screens at the same time. Then they have a program that scans for identical documentation in all 4 screens. And when they find it and they see that you have the same verbiage in every single chart, they won't count that as being patient specific, so they won't count it in any chart. So you don't want to go overboard using your canned documentation. And if you do, overuse that, you can increase the odds of an audit. So speaking of audits, beginning in 2026, Brault is going to offer a new service to you where we will review your charts for overall content, looking for things that might trigger an audit, that might be problematic or potentially detrimental to you if you keep them in the charts. These are only going to be 20 to 30-minute sessions, but will help you tighten up your documentation, help you reduce the risk of an audit, point out things that may be more harmful than helpful. Sometimes, oftentimes, less is more. So if only certain things are required, it's best to confine those things to your documentation, to just those things, such as a simple critical care statement, rather than elaborating 20 things you did to be considered for critical care. So when you sign up, these will be on our Calendly links. Option of choosing between a documentation review to see where you're leaving RVUs on the table, or a chart review where we'll look at your charts through the payer's lens and help you reduce areas where you may be at risk for an audit. Lastly, you want to make sure that you're not willingly leaving RVUs on the table. These are just missed opportunities, and you're leaving behind revenue that you have rightfully earned just because you didn't get the right verbiage on the page. Remember, for every interpretation, whether it be an EKG or imaging, you need to include the words "per my interpretation." If that's missing, we cannot give you credit. And every time we have to reduce the level of a chart because those words are missing, you're going from level 5s to level 4s or level 4s to level 3s. And that can be avoided just by making sure you're using those words. You can't say, I reviewed the x-rays, or I reviewed the x-rays and per radiology's interpretation, or EKG shows. You need to be specific and include per my interpretation, or EP interp, or interpreted by me every single time you document an interpretation in the chart. All right, at this point, I'm going to turn it back over to Dr. Brault, who's going to give you some real specifics that we've learned.
Alrighty, thank you, Diana. And so what we're going to talk about in this section, well, really, as opposed to what Diana just walked you through, which is there's a couple of payers that use sort of a black box approach. And it goes beyond just the diagnosis, although that is sort of the first step in the process. In this section, we're going to talk about payers that have published their process, and they are using what they call, well, what is called the low acuity not an emergency. LANE is the acronym list. And so if we move on to the next slide, right, we are those of us that are older, familiar with the diagnosis list, right? And if we look sort of at the top line, Billings was a study that came out actually kind of late 90s, and then there were some republications that looked at what happens when there's no Billings was actually looking at when there's no primary care, what happens inside the emergency department when there's no primary care in the community. And unfortunately, payers took that data and those final diagnoses and began to say, well, people don't belong in the emergency department. And so along comes Truven that looked at patients presenting, commercial patients presenting to the emergency department, and concluded something like 50% don't belong there, which gave payers a lot of angst, and they began using final diagnoses against us, which of course you can't do based on prudent layperson, but that doesn't stop the payers. What I do want to call your attention to before we move on from this slide is most recently there was a study in May of this year published by a company called Trilliant, and it was a horrible study. It looked at not just emergency medicine, but it also looked at urgent cares and doctors' offices, and it looked at the last couple of years, and it crossed the change in CPT. So first it was pointing to offices and urgent cares, and it said, my gosh, look what happened. All these 3s became 4s. There must be, weird coding going on here. And then it looked at the emergency department, and in 23, look, all these 3s became 4s. There's rising acuity everywhere. Everyone must be doing some funky coding, totally missing that, 1, there was a pandemic happening during the years they looked at, and 2, that for both office and urgent cares, there was a change in their coding methodology, and then we followed right in 23. Like the people who did the study didn't know what they were doing. The problem is the results of this study went viral in May and June of this year, and so payers are sort of on the path of there's something wrong. The coded acuity has gone too high. It's in the coding process, not the actual acuity of the patients. So be that as it may, there are payers that have published the use of the diagnosis list that they're going to use. The earliest list that I looked at, actually, we can work with it, right? So the low acuity, not an emergency list basically says if you use only these codes and nothing else, your claim is going to be downcoded. We don't agree with that, but let's go through it a little bit, and then there's some strategies to work with it, right? So if you have only simple minor injury, abrasion, contusion, sprains, strains, pain in whatever, if you pair it with the cause of injury, right? It was after a car accident. The child went on, flew through the air from the swing set, ground level fall, right? If you pair it with its injury, it will not be downcoded, right? So every time you're looking at someone with an injury, tell us that there is the injury and also give us the date. Next slide. Now, if you just have simple symptoms, that's a little harder, cough, dysuria, fatigue, insect bite, nausea, swelling. That's a little bit harder, but we're gonna talk about these in just a minute. And some of these lower level diagnoses, if you pair them with nothing else, right? You just write, conjunctivitis or bronchitis, sinusitis. The claim does get downcoded to a 3, although hopefully you all are reading Diana's monthly bulletins. She talked about some things to pair these simple diagnoses with if you did a higher workup, right? Because they came in with a more concerning symptom or presentation, right? If it's more like a 4, right? Give us the other information about that patient, the other symptoms, right? And then the claim will be processed appropriately. But if we look at more common presentations, more complex presentations, and I think the first one we have is abdominal pain, right? That's the super common one, right? But if you bring forth comorbidities, any abnormal lab findings, vital signs, physical exam findings, right? And then give us more information, sort of, the severity, the specific location, there's fever, vomiting, right? Those things we can bring into the diagnosis and onto the claim, and that will avoid the downcoding, at least by the payers so far that are publishing that they are using the Lane diagnosis list. And I think we have chest pain next. Again, another really common one, especially for these patients. We want to talk about the comorbidities that made cardiac ischemia more likely. So are they diabetic, hypertensive, high cholesterol, nicotine dependence, right? That is an actual I-10, right? If they, lab findings, were they tachycardic, were they hypoxic, were they, again, hypertensive? Lab findings, did they have a high troponin? And then, of course, if their EKG was abnormal in any way, that's also really important to bring down to your diagnosis line. Weak and dizzy, my personal favorite, it codes out as dizzy and giddy, right? It just doesn't code out to something that sounds like a 99285. We all know that it is, right? That's, just the proverbial mama doesn't look right, she's weak and dizzy, and oh my gosh, we're off to the races with our differential. But, bring to the diagnosis line the other things that were going on in that presentation. Was the patient altered in any way, disoriented, any abnormal lab findings? Were they hyponatremic, hypokalemic? Vital signs, were they tachycardic? Were they tachypnic? Were they hypertensive? All of these things can be brought into the diagnosis line to avoid the downcode. And certainly, again, any comorbidities, complicating factors, we'll talk about, like repeated falls is one that avoids the downcode. Dementia, again, another one that'll avoid the downcode. Respiratory complaints, real common this time of year. Again, abnormal vital signs, if they're tachypnic, if they're hypoxic, if they have, again, this is something that spurs the higher level workup, right? Their COPD, their asthma, they're still smoking, fantastic, right? Nicotine dependence, complaints, I'm short of breath, use the words acute cough, right? Certainly note if there's wheezing on their exam, bring that down to the diagnosis line. These are all things that'll help avoid that lane diagnosis downcode. All right, key takeaways. We're coming into the home stretch, right? So again, when you think about, we were taught forever, think in ink, right? That's your medical decision-making paragraph. Bringing that on down into the diagnosis line, right? Because that's now, that's the only thing that gets communicated to the payer, your CPT, your diagnosis, and now we want to bring your medical decision-making into the diagnosis line so we can really round out the story for the payer, right? So abnormal lab values, so things like a high white count, a high troponin, a low sodium, a high potassium, any of your abnormal vital signs, anything on your physical exam, things like bruising, wheezing, nicotine dependence, diabetes, end-stage renal disease, any of the other comorbidities, always your external cause of injury, always, please help us by including the date, an abnormal EKG. If you felt compelled to record a Glasgow Coma Scale because of the type of injury, that's there are I-10s for that. If you felt compelled to record a stroke score, there are I-10s for that. Repeated falls is an I-10, right? So you're doing a workup, you're doing a big workup because, daddy didn't look right, daddy's been falling, right? Bring that on down. Of course, any social determinants of health that impacted your ability to, or that caused you to do a different workup or more broad workup, or change your disposition, bring that down. Unsteadiness on feet, that's a classic, and that also helps avoid that lane diagnosis downcode. All right, key takeaways. As Diana mentioned, there's some factors that are not within our control as we head into 2026, but there are things that we can do, right? Sort of, again, bringing more of those diagnoses down to the bottom line so we can communicate a fuller and more rich story to the payer, really kind of bringing into sharper focus the risk for that individual patient. Right. So when you think about the process that's occurring now for many of what I call the black box payers, we send a claim to the payer. They immediately post up some information for us that we can see that says, send us the charts. They didn't used to do that before, but now with AI and the large language models, it's just like claim, send us the chart. We load up the chart and they feed it through their black box. Right. And so, as Diana mentioned, they don't follow ACEP FAQs. They're following some other algorithm. And so the more sharply that you can bring into focus for this patient, they were high risk specifically for these reasons. So bringing that into focus, and then meeting with Diana and Janice and learning kind of, is my documentation style too, I don't know if this is a word, but too macroed. Right? Is it going to get caught in this sort of wheel that they believe that I'm just templating everybody and that I'm not specific to my patients, that I'm just sort of gaming the system? Not that you are, but of course, that's what they're looking for as well. So I definitely encourage an opportunity to review your charts. And all right, I think we're going to the questions. The first question up is, does it matter what diagnosis is listed first? It does, but our coders are also trained to know which diagnosis should go first. But ideally, and Diana is going to ask because she's the more experienced coder, but I'm also a coder too. So ideally, go ahead.
No, I was just going to say, it really should always be the highest acuity diagnosis listed first. I'm not sure that facility coders have the same leeway that profi coders do, but you don't want to say bill critical care and your first listed diagnosis is a UTI and your second listed diagnosis is sepsis with AKI. So you always want to try and list your highest acuity diagnosis first.
All right, I'm not seeing any other questions. I'm going to throw one to Diana. If you could wave a magic wand and change one thing that you're seeing in the pattern of documentation, because you review hundreds, if not thousands, of charts in a month, what would be the one piece of information you would pass on to our clinicians?
The easiest one for you to change, and that will make the most difference in your overall reimbursement, is to remember that phrase, per my interpretation. I can't tell you how much money is left on the table every month because we can't count those interpretations because they're missing the interpretive statement. The payers have fixated on the guideline verbiage, and it says in order to qualify for those data points, you need an independent interpretation. There is a difference between a review and an interpretation. I can review an EKG, but can I interpret it? That's a big difference. So you need to actually document that you are interpreting those studies to pick up those RVUs. Those data points really very frequently mean the difference between a level 5 and a 4. And if they're going to take away portions of practice expense and other things from us, we don't want to give them more voluntarily by not documenting to the best of our ability. So the one thing I would suggest is make it a point to add per my interpretation every time you document your review of the results of x-rays or an EKG.
Yeah, thank you. I would agree. I just finished a big review myself, and I can't tell you how many times, or big chart audit, and I can't tell you how many times I saw per my review, and I was just like,
one other
okay,
thing that I just want to throw one other thing out there. Some of the payers are not giving appropriate credit for differential diagnoses. Those are the things that you need to rule out to safely discharge a patient. But they're just because it's listed as a differential, some payers do not give the credit they should for that. So if you can incorporate in your MDM documentation, I ordered a D-dimer to rule out a life-threatening PE, and use those words, life-threatening. That increases that problem category so that the payers know why you ordered the study and that you were considering a life-threatening diagnosis. So anytime you can do that, I ordered a troponin in order to rule out a life-threatening MI. So those things are, I ordered a CT of the abdomen to rule out a complete bowel obstruction. Those will help you if you incorporate that little bit of extra information in your documentation.
All right, I'm seeing a number of questions now. Should we be listing as many diagnoses as possible, i.e., let's see, all of the patients, and it cuts off on me, chronic, I'm going to assume chronic disease processes?
No, the only time you should be addressing or listing in the diagnosis section patients' past medical history problems is if they factored into your decision making. If the patient has hypertension and you couldn't use a certain medication because of that, then their hypertension was addressed in your decision making because of your choice of meds. But you shouldn't list that they have migraines and they have hypertension and they have diabetes and all of that if you're treating them for a sprained ankle. It's not pertinent. You didn't address it. So if it's in the diagnosis line, it should have been part of your medical decision making or addressed or considered in some way during the visit.
And I think that's really important, Diana, because payers are watching. And so we do look for ways to make this process more efficient and less difficult for our clinicians. But when you cookie cutter it too much, and like you're saying, all of a sudden it's a sprained ankle and we're listing every disease process they've ever had, it just smells. Like you said, the payers are going to pull up 4 at once and go, oh, they do this for every patient, no matter how low the acuity. And so we're not giving credit when you're listing, chest pain, diabetes, hypertension, when we are trying to say, hey, look, this is a patient who needed a full cardiac workup that was truly a 99285. Next question. Have you noticed any problems with the documentation via AI scribes? And Diane, I know you've done a fair number of focused reviews for our clinicians.
The good news is in the charts that I've reviewed that are known to be using AI, I haven't found any significant deficiencies or things that are missing. In many cases, it's very complete, and it's also patient specific, which I was really pleased to see. So most of the ones that I've reviewed, I still have more on my list to review as you know, clients let me know they're using it and want me to take a peek at their documentation. But so far, the news has been all good.
Okay. Okay, can you expand on the requirement for the MD to attest to the APP chart? So we did not cover that today. It's a great one. We were under the understanding that other payers besides Medicare are now requiring the attestation, but not sure how widespread it is or necessary the attestation is.
It applies to all payers, and we introduced that information at the beginning of the year, that all payers require an attestation in order to get credit for a split or shared service with an APP. Essentially, we still have the same three categories on the coding grid: the problem category, data category, and risk category. And the person who's listed as the attending provider is the one who did 2 out of those 3 categories. So if it's the APP and there's no attestation to indicate that the physician also did that, then we're going to bill under the APP as the attending with the physician as primary. But if the physician documents that they were consulted by the APP and they are taking the responsibility for the problems being addressed and the risk of the patient management, that is sufficient for 2 categories, risk and problem. However, if there are any interpretations in the chart, if the physician doesn't document their own interpretation, we can't give credit for it. So you could have a template that says, I was contacted by the APP to consult on this visit. I take responsibility for the patient's presenting problems and management. Patient also had an EKG, which I interpreted as rate of 72, normal sinus rhythm, normal axis. Sign your name, and we can bill it under your provider number.
And to maybe take that just a step further, understanding that some physicians are uncomfortable with that, right? That language is about whose name will go on the claim to the payer, right? So this is about, we had Medicare rules forever, right? And we used to teach you all about face-to-face so that the physician's name could go on the claim to Medicare and you could avoid the 15% reduction. And then over time, some commercial payers started to reduce payment if the patient was only seen by a nurse practitioner or a PA. But now CPT and Medicare have come together, and CPT has language in it that talks about whose name goes on the claim. And that's what Diana is talking about, is we're looking for documentation, right, to compliantly determine whose name will go on the claim. And so we should probably even do a whole webinar on this. We could talk all day. And whose name is going to go on the claim. And then, of course, we also keep track in our system of who else was involved and who touched the patient. So you heard her mention the name primary, like there's other things that we keep track of, but the documentation drives whose name goes on the claim, if that makes sense.
Keep in mind also that if the APP documents a level 5 chart and the physician does not have an appropriate attestation, we'll still bill a level 5 chart, but it will be the APP in the attending spot. There is no downcoding of charts because the physician didn't provide an attestation. It only means whose name ends up in that attending spot. We will always bill to the highest level of documentation. And if it's by the APP, then that's who it will be billed under.
All righty. I am not seeing any more questions. I think that is it. All righty, everybody. Thank you so much for your time today. And there is our contact information. If you have other questions or more questions, please do feel free to reach out, and we'll be happy to chat with you. Thank you so much.